Good evening. My name is John Brofonsky. I'm the Chief of Police here in Bedford, New Hampshire. And this is our May 22nd speaker series for BeBOLD, Bedford Building Our Lives Drug-Free, Bedford's very own Substance Abuse and Drug Coalition Prevention and Education Coalition. Tonight we have three special guests. We have three Bedford docs here to talk about substance abuse, and I just want to introduce each one of them. First, beginning with Dr. Kevin Desrosiers. Dr. Desrosiers joined Elliot Hospital here in Manchester in 2010. He's an adult intensive care physician and serves as the medical director of performance improvement for the Elliot Health System. Completed medical school at Dartmouth Medical School in Lebanon, New Hampshire. Completed his internship as well as residencies in internal medicine, preventive medicine at Dartmouth Hitchcock Medical Center, and completed a fellowship in critical care medicine at Dartmouth Hitchcock Medical Center. In addition to clinical work, Dr. Desrosiers has a strong interest in public health. Completed a master's in public health degree at Dartmouth Institute for Health Policy and Clinical Practice. Thanks for joining us, Dr. Desrosiers. Next is Dr. Stephen Loosigian.
Perfect.
Thank you. It's like Brofonsky, right? Dr. Loosigian has been with the Elliot for 16 years. He's the director of the Hospitalist program at the Elliot Hospital, and the vast majority of his clinical practice involves critical care medicine. Dr. Loosigian completed his internship and residency in internal medicine at St. Elizabeth Medical Center in Boston. Dr. Loosigian graduated from medical school at the University of New England in Maine, completed a master's degree in biology from Harvard University, and a Bachelor of Arts in Economics from the University of Colorado. Dr. Loosigian is board certified in internal medicine. Thanks for joining us, Dr. Loosigian.
Thank you.
And finally, Dr. Greg Baxter. Dr. Baxter practices emergency medicine in Manchester. Dr. Baxter graduated from the University of Vermont College of Medicine in 1995, been in practice for 22 years, completed a residency at UMass Medical School. Dr. Baxter accepts medical insurance plans, including Tufts Health Plan.
And Medicaid, too.
We have a clinic outside right after this, if you need to see the doctor. Dr. Baxter is board certified. I'm just reading this. Dr. Baxter is board certified in emergency medicine. In addition, Dr. Baxter's practice supports Spanish as well. So thank you all, docs, for joining us here tonight. And appreciate you taking your time out of your busy schedules to join us here for BeBOLD's monthly speaker series. For those of you who haven't been in the audience in the past, every month during the balance of the year, we take the summer off. We have a monthly fourth Monday of every month here at the Bedford Library when we talk about subjects related to substance abuse prevention and education. And tonight, our special guests are here to talk about what they see in the medical profession, the changes that have occurred most recently in the last year or so with respect to pain medication, pain management, the prescription drug monitoring program, which you may have heard about and you'll hear more about tonight. What they see in the hospitals with respect to the types of treatment, the evolution, if you will, of the types of substance abuse problems. I'd like to hear from you personally about what you see with respect to young people in terms of any progression that you see from certain types of ER visits, not necessarily opioid related, right? We often think now, because of the opioid crisis here in New Hampshire, third worst in the nation, that we typically focus on just opioid, fentanyl, in those types of substance abuse cases. But you do see cases with respect to marijuana, alcohol, and other types of prescription drug, pain medication types of substance abuse cases. I'd like to hear a little bit about what you know and see in the hospitals regarding that. So, without any further ado, docs, you have the stage.
Well, thanks, Chief. And on behalf of Kevin and Steve, we're really happy to be here tonight. And thank you to Mike Fournier for inviting us and allowing us to talk to you on behalf of the community and the Elliot Health System. So I think our plan tonight is really to communicate to you as physicians, but probably more importantly, all three of us are parents, and citizens of our great state, and we want to talk from that perspective as well. And maybe after a few prepared comments we all three of us have, we'd open up a dialogue with you and we answer some of your burning questions that we didn't cover. There's no questions that's off limit. I think we try to answer as best we can. So my comments are going to focus on three areas. I'm going to come back to sort of the current state, as Chief mentioned. I've been in practice about 20 years, and I've seen quite a change in the range of patients that I see and some of the suffering that they have. I'm going to talk a little bit about what I would offer as some guidance around some prevention as parents and things that you can do. And the question I get all the time I'm going to lead off with, so does an acute injury, a broken bone, a surgery for a rotator cuff, an ACL repair, one of these things, and the pain management set your child up for problems, okay? So your child goes in, has a routine surgery, not routine for you, but routine for us, and there's a prescription for Vicodin or Percocet. And I would say unequivocally, no, that does not set you up for trouble. However, you've got to respect that medication, okay? I would say we've come to realize, I've been doing this 20 plus years, and when I started training and when I was first practicing, our respect for these medications was really poor. We just didn't understand how dangerous that they were. And so I might give someone a prescription for 20 or 40 Percocet for a broken forearm. In hindsight, I now know that after the first couple of days when the cast is on, the amount of pain from that's actually not very much. And I would encourage you to think about all the adjunctive medications, so ibuprofen, Tylenol, ice, elevation. And then these other medications, as directed, as prescribed, as indicated. So for breakthrough pain, not taken around the clock, not taken because you're told to take it. It means as needed. And so that's one thing I would offer you. Second, what can you do as parents? I think it's modeling behavior. So I won't ask anybody to raise their hand if they've ever taken a medication that wasn't prescribed to them. But I have lots of friends, thankfully, and almost all of them that I ever poll have said at some point in their life they took a spouse's medication or a parent's, a sleeping aid while on vacation. I can't tell you how toxic and dangerous that is for your child. Because what you just told them, it's okay. And when they model that behavior at a pill party, you shouldn't be surprised. So, I won't do that in front of my child. I'll admit, in my lifetime, have I done that? Yes. Not proud of it. Didn't realize the danger that I might have been in. But I also didn't have children, and I surely won't model that for them. So I'm not being pious and overstating this, but take the medication seriously, take them as prescribed, only take ones prescribed for you. And if you have to, make a point of it. That, Mike could say, no, Kathy, I think, I have trouble sleeping, I'm going to speak to my doctor about that. I won't be on vacation taking an offer from a friend. I use Mike for an example because he's a great guy. But you know what I'm saying? Like, these are really simple things that you can kind of walk down a bad road and you could show your child in a way you're not sure about. So the last thing I'll tell you is, in my 20 years, I used to see kids with alcohol abuse. Parents away for a weekend, the apocryphal party, too many drinks, the kegger that shouldn't have been at age 17. That's not good either. That switched about 10 years ago. I started seeing more and more kids with a combination. Dr. Ram Yadadi is in the audience today. He's another Bedford doc. He's a practicing psychiatrist at Elliot. Thanks, Ram, for coming. Behavioral health problems, mixed in with a bit of a substance abuse, so maybe some depression or anxiety. Maybe dad's Percocet that was around from an oral surgery in the cabinet might be a way to kind of chill out for the evening. And then I started to see the next steps. And the one common path I can tell you is it doesn't always start with prescription medications, but here's something it always comes with. It's a progression over time of usage that increases a dose and the aggressiveness and the craziness of which you take it. So from a pill to snorting to intravenous drug use. And the other thing that's common to that pathway is the absolute destruction it wreaks. Okay, I've seen people from every walk of life, physicians, attorneys, accountants, elected officials of various types, actors, actresses. I used to practice in Massachusetts. Run-of-the-mill folks, every one of them has the same story. They got into a situation they cannot control. I will tell you, there is no such thing as recreational substance abuse. That phrase is an oxymoron. There is nothing good about it. Nothing good will come of it. And everyone I talked to found themselves in a position, sometimes months, sometimes years later, unsure how they got there, but unequivocally knew they had a problem. Here's what I'll leave you with, because I think Kevin and Steve, who take care of their patients, I admit, for serious complications of drug use. I have seen people, dead or near dead, receive an antidote called Narcan. You probably all heard about that. Brought back from the dead, literally brought back from the dead. Have such a craving and desire and absolute inability to control that craving. They sign out against advice, brush past me because I can't attenuate their events. I can't make them stay. And they've been back within an hour dead from the same drug that they just took, which just killed them the first time. But this time not so lucky. This time it's for good. So I tell you that story to create a bit of a boogeyman. If you have questions in a friend, in a child, ask. Push them. Right to the point you're uncomfortable. Don't leave it to be an assumption. You think things are fine, maybe he's just having a bad day. If you're sensing something's not right, it's always better to try to point them towards help. And we do have legitimate help. Dr. Udati could tell you, we have medication-assisted treatment, we have behavioral therapy, all of these things we can do, but you've got to seek it first. And one of the ways I've seen it done really successfully is when someone recognizes a friend or someone they care about is struggling, and they intervene. And you got to catch the person at the right place that's ready to hear you. Take the risk. What are they going to do? Get upset with you trying to save their life? That's a risk I'd take. So I'd offer you that. I'd offer you the fact it's definitely not something you want to dance with. There's no recreational substance abuse. And it's changed significantly, and we can have a bit of a dialogue about that. But I want to turn it over to Dr. Loosigian to talk to you about some of what he sees on the inpatient side of the hospital.
Thank you, Greg. My name is Steve Loosigian, as I was introduced earlier, and I'm happy to be here tonight. You know, I prepared some notes, and I thought I might talk about the physician drug monitoring program, but I think I'm going to pass over that for now. I don't think that's super high on you guys' mind. I think, in general, it's pretty onerous to abide by the law on a daily basis, and it's had some effect on our prescribing habits. I don't know if that's good or bad, quite honestly. I think some people are getting narcotics, who should be getting narcotics are not, just because it's so onerous to prescribe them. And I think some people who shouldn't be getting them are not getting them, and the law is probably working to some extent too. In the aggregate, I don't think it's going to have a big effect on the problem. I don't think we can legislate our way out of it. But that's about all I'm going to say about that. You know, I do work in the inpatient world, mostly inpatient on the medical floors these days. And there are many, many components to addiction. You know, there's the physical, the psychiatric, the social, the medical. What I deal with is the medical, and that's why I'm going to stick with that. You know, Dr. Udati can talk about the other things if anybody has questions related to that. But I do want to recognize and admit that they're all related and all tied up, and we do have to look at them all as we work forward. As a little bit of a note here, there's today 103 patients on my medical service of the doctors who I work with. 10 of them are there strictly for IV drug abuse issues. That's not counting the ones who have peripheral medical complications because they also take IV drugs. And 20 of them are there for alcohol issues. So 30% of the people in a medical floor in the Elliot Hospital right now are locked up because of drug and alcohol abuse. 30% of the resources we spend, millions and millions of dollars, are going there today. You know, the people, I went through the ages today, they range from 24 to 55 years old. And I thought it might be interesting just if I tell you two stories about two patients I've seen over the past 6 months. And these are people with complications, because that's who I see. Greg sends the ones that can go home, and the ones that can't to me or to Kevin, depending on how sick they are. The first of these two cases, where am I here? Sorry, it's a 24-year-old white male who came into the hospital about 8 weeks ago. Initially came in with a fever, a history of IV drug abuse, and a left wrist pain. He was worked up by orthopedic surgery, by infectious disease. He had MRIs. He was found to have osteomyelitis, which is an infection of the bone. Very difficult to treat. 6 weeks, IV antibiotics. Somebody who had it, who was not an IV drug abuser, may go home and actually take IV antibiotics at home. But you really can't discharge this young man because you're discharging him with a peripheral IV that he can shoot his heroin into. So he's stuck in the hospital for 6 weeks. He signed on against medical advice after 2 weeks to use. Got high, came back a week later with the arm much, much worse. Was taken to the operating room. The arm was drained by orthopedics. Dr. Parisian did that. And now he's completing his course. He's been in the hospital 6 weeks since the surgery. His arm is getting better. He's probably going to get to keep the arm. But the problem I see is he's going to use again. I mean, it almost feels like a total waste, right? He comes in, he spends 2 months in the hospital. He's going to go back and use. And my role is the medical doctor, but every time I even try to bring up the conversation with him about using again, he's offensive. I've offended him by even talking about this. So I think that it's pretty obvious to me that if he's not even ready to talk about it and admit it, that's a profound problem for him, society, for everybody. The next case I was hoping to mention is a 33-year-old female who was admitted to the hospital about 6 months ago. Similar symptoms: fever, chills, history of alcohol abuse, blood cultures, imaging, ultrasound of the heart, which shows the structure and the function of the heart. Ultimately turned out to have what's called endocarditis, which is an infection of the inner lining of the heart, usually one of the valves. She got treatment for a few weeks, was decided she needed surgery, so she had cardiac surgery. I mean, they split her chest open. We sent her to a CT facility. We don't do cardiothoracic. They went in, they repaired the valve, sent her back. She completed her 6 weeks of antibiotics, discharged home. She used again, came back with a new infected valve. I mean, think about that. I don't know, 100 grand, 200 grand, months in the hospital, and valve shot again. You don't get a second valve in today's society. You get one. She died. Came back, died in the hospital. Long, prolonged. You don't die quickly of this. It's just a long, prolonged thing. I don't know if you guys have any questions about those cases. I'd be happy to answer them, or we could move on to Kevin and talk sort of big picture stuff.
Steve, do you ever feel like there are, when you see these patients, is there a theme or a pattern of aha moments that gets them to the point where they feel like they want to make a change? So you had mentioned the young man went AMA.
Mm-hmm.
Or is it just they have to be ready? What does it look like in your perspective?
Yeah, I mean, they have to be ready, and this is going to sound really cynical, but I've almost never seen an aha moment. I mean, it is so powerful. You'll lie, cheat, steal money out of your mother's purse, and it's just, it doesn't seem to mean anything. I've never been addicted to drugs, but it's profoundly powerful. And I don't know if
No, I would tell you, Mike, I've never seen an aha moment.
Never in 20
The story
years.
I told you of someone who left the hospital an hour later. Think about this. You consciously injected a drug into your arm that just killed you. You know that. You left. You did it again. So there's no logic, right? There's no reasoning. I mean, it's out the window. But I want to be careful. I don't think Steve and I, or I'm sure Kevin, I would never say I don't have empathy. Right. I'll keep banging my head against that wall. I'll keep trying to have a conversation. Can you open up? Can I get somewhere with you? Can I get you to a place you start to see this? I'll try every trick I can think of. Offer the therapy, offer the treatment. I don't judge. That's not my job. But I'll definitely acknowledge with cold, hard facts what you're doing, because you can't be subtle about this. Because what you're doing isn't subtle to yourself. I've just never seen that light bulb go off. There's a whole science to that. Ron may have comments.
Are always hindsight.
Mm-hmm.
Those aha moments are always hindsight. I think recently I saw one patient who almost came to that aha moment when she realized that her mother also died of a drug overdose. So it's very personal, very painful, and the struggle is that trying to find how is that we can get to that aha moment. It's very sad.
So, just to talk about the aha moment for a moment, some of the folks that may have been here for a previous speaker series, you've heard me talk about some of these aha moments. One of the young men that we had here a few months ago who was addicted, and his dad, called it a white light moment, okay? They didn't call it an aha moment, they called it a white light moment. And the white light moment trigger for that young man was the family disruption, dysfunction that he caused with his dad. For me, I've had a couple of white light aha moments with people that I've come in contact with that I've arrested or been arrested by the Bedford Police Department. And through that moment of despair where they know that they're going to go to jail, and they've been to jail before, so jail is not a frightening thing to them. But in the context of going to jail again and talking about the likelihood that you're not going to see your unborn child grow up, you're not going to be able to see your family because you're not going to make it. And you start asking them, how many friends that you know have died? So you look for that trigger, and we call it, we give it the pitch, right? And there's no one trigger that works for everyone. And if the doc, and I think when they see the docs in the white coats, they expect that no matter what happens, they're going to be able to fix them. That's the expectation. right? When they show up at the hospital, these guys in the white coats, they're giants. They're going to fix me. But it's not the same with family issues. So there are different triggers, is what I'd like to say.
Absolutely. Good point.
Not to contradict what you say, I'm hospitalist as well. I take care of patients in different institutions. And I have to say that we see the sickest of the sick. And sometimes we take care of them for 6 weeks. And I have seen some patients going through aha moment. But even if they want to seek the different path, the psychological dependence is so strong, and we are medical doctors. We treat the medical dependence, and sometimes they get clean from the medications physically, but that pull is so strong. And now we have a way that when they are discharged from the hospital, they go to treatment, Farnham Center, etc. That is a new thing. It's wonderful. Many of them come back. Many of them go through medical treatment, then they go through facility to be treated for addiction, and they fail. And there is a literature that says that many of them fail 3-4 times. And it's not that maybe they didn't have the aha moment. Many of them do want to break that cycle, but the addiction is so strong that despite of the will and despite of the aha moments and despite of their desire to actually break through, many of them are not successful. And what we see are really those.
I think that's an excellent point. We're defining aha moments slightly differently. You're defining it as having the moment. I'm defining it as having it and succeeding in staying off the mark.
So,
Sure.
you.
Hi, my name is Kevin Desrosiers. I'm an intensive care doctor at Elliot Hospital, so I spend most of my clinical time in the intensive care unit. We get our patients primarily from the emergency department. And, you know, even thinking when I first started practicing, we rarely saw patients who overdose on medications. If they did, sometimes it was accidental overdoses or medications that they took accidentally. Now, we definitely see significant more of recreational or addictive drug use, injection, IV heroin primarily, and fentanyl. And oftentimes these patients are not presented to the hospital via their own means or even via EMS. Oftentimes friends will push them out of the car on the curb, and we hear a medical alert response, and our staff kind of goes out to collect them. And often this was due to fear of some sort of, you know, arrest, or that the friends would somehow be held liable, so they didn't want to be really affiliated with these people or their friends at all. And you know, we think about the fact that your friends who you're using drugs with really wouldn't even be able to bring you into the hospital. They're lucky if they'll push you sort of out of the car at the curb. And from that point, you know, we'll give these patients Narcan. And the ED staff in the past, these patients would immediately be intubated. We'd put a breathing tube from their mouth into their lungs. We'd transport them to the ICU. If we were to do that now for every patient who came in with an overdose, we would not have the capacity in our ICU to be able to take care of those patients. And so we often are able to treat them with Narcan for a period of time and then discharge them directly from the emergency department, which would have been crazy talk, you know, 3 or 4 years ago. But from where we are, that's oftentimes what happens. And the patients that we end up taking care of are patients who have been unconscious for so long or not breathing for so long from taking opiates that they actually start to have brain damage and they're not waking up. And so from that point, they need to be on a mechanical ventilator or a machine to help them breathe. And then our hope from there is that they're not actually brain dead. Some of them do progress to brain death over a period of days to weeks. Some come in already brain dead. And at that point, there's nothing that we can do to undo that. Many of those patients are young. And you know, we see everything from patients who have no family or really no one who they know that particularly cares about them. Others who have enormous families, so families so big we can't accommodate them in the waiting rooms, who've been supporting them through their addiction and recovery, and who maybe have been on their 3rd or 4th relapse, but it only takes the one time where you stop breathing to the point that you could have significant brain damage and then really no longer be able to regain meaningful life. And those cases are particularly sad. We're in regular contact with the New England Organ Bank, and you know, we recently had a survey of our trauma program, and they evaluate how well our organ bank program works. And it's sad that we're actually, you know, quite astute at the process at this point because we go through it so frequently. So I did pull the statistics from Julie King, who's our coordinator from the New England Organ Bank, and I'll just give you those numbers. So In 2014, there were 44 organ donors who donated organs related to drug causes, and that represented 16% of the total number of organ donors we had. In 2015, that rose to 19.1%, or 58 out of 282. And through 2016, that number increased again to 94 out of 338. So 1 in 3 of our patients who donate organs are donating them because they died of a drug-related illness, particularly in an overdose or abuse. Fortunately, in 2017, so far, through April 30th, we're at 17.7%, so maybe there's some hope there, but we oftentimes see our toughest times are in the summer months when the parties are a little bit more robust. And so, from the organ donation perspective, oftentimes those families who make the decisions to help other people through the organs of their loved one who died, it's sort of the only silver lining that they have. But it's very sad in the same sense that these are oftentimes 21, 35-year-old organs, very young people who are needlessly dying at the hands of heroin and oftentimes fentanyl. And so, as Greg pointed out, and we had this conversation a lot, the opiate epidemic is difficult on physicians because I think we do see many patients who we encourage to stop using opiates. And if it were only that easy, they would all say yes. And I think we need to think about harm reduction and repetitive contacts with patients. So if we can't stop you from using heroin, can we encourage you to use clean needles? Because we know oftentimes the effects we see from the sort of organ dysfunction, if it's not for brain death, it's for endocarditis or osteomyelitis, infections from using needles that have been used before, or having the impression that using Poland Springs or some sort of water that comes from a bottle is somehow cleaner or sterile, when oftentimes, it's not. And so this addiction is so strong. When your brain gets exposed to this for the first time, that novel response, it will chase forever at escalating doses. And so, we really try to think about, if we get to know these patients, and many of them we know very well from multiple admissions for very severe medical conditions, is how do we help them kind of meet them where they are and reduce harm. I'll tell you a couple of stories, and then I also want to relate, Dr. Udani, maybe you can comment a little bit on the increasing use of Subutex, which I think has significantly reduced harm. Essentially, it takes away that yearning to get the drug. And then we also have medications that treat the itching and all the other treatments that go, or symptoms that come along with withdrawal from opiates. And I think as we sort of change our model from thinking that, we'll kind of scare people straight being in the hospital the first time they have an incident, to really thinking about how do we reduce harm as we help to treat the opiate addiction till we can meet people where they are when they're really ready to stop using drugs, is very important. So I just had a few stories to tell you. So we recently took care of a patient who actually didn't live in New Hampshire. He was visiting from another state with his family. And he had actually traveled with a companion who was a new girlfriend, and together they had used IV drugs repeatedly. And he was found unresponsive in a car and had been there for likely several hours. So he wasn't waking up and had evidence of some brain damage. And when we did the ultrasound of his heart, we saw that, in fact, he had quite a big collection of bacteria in the left side of his heart. And part of the reason he was not responding was because that bacteria will oftentimes break off from the heart and travel directly to the brain and cause a stroke. And unlike a blood clot stroke, we can kind of break that up. This is just a bunch of bacteria blocking blood from getting into your brain. And there's really no way to treat that. And you have to hope that patients can recover. And while he was slowly recovering, day by day, meeting with his family, who's far away from home, essentially living in the hospital, that we're hoping we can get him well enough to potentially eventually have a surgery to replace that valve. But of course, 3 or 4 days in, during that recovery period, he had another stroke from another big sort of breakage off of this bacteria, which effectively ended his life. And when we see how much this devastates families, great families who are really supporting the people that they love, it's heartbreaking because it's all very preventable. It's very needless. And I think as a physician, we see our helplessness, which I think we're not really used to with the technologies we have and the diagnoses we can make, but we're essentially helpless against the powerful nature of the addiction in this case. I've seen many young people who have children present, and many of them will tell us, they don't really want to discuss their drug addiction because they've been trying to hide that so they can try to get custody of their children back. And so oftentimes they don't want to be admitted to the hospital. They really don't want any records released of their emergency department visit because they know that will impact negatively on any custodial hearings they have for their children. And I took care of a young woman recently who had this issue, admitting her from the emergency department because she required a continuous infusion of this Narcan medicine to even stay awake. And during that time, we learned that she had hepatitis C, which is a very treatable disease, which she elected not to be treated for because she really needed to leave, again, fearful that she might not regain custody of her children if they knew that she was being treated for IV drug-related diseases and relapse of her IV drug use. And so there's a lot of social barriers that we place as well in terms of getting recovery and the stigma that comes along with drug abuse and dependence. And so, again, really thinking about harm reduction and how we're going to accomplish that is a really important mindset as we think about trying to get people to recovery. The last one I'll tell you about, again, is a young woman who had a stroke. She actually was in her early 40s and had children who were aged 19, 16, and 5. And they were her only sort of living relatives. And they came to the hospital after we called and said, your mom had a big stroke related to this heroin. And they asked a lot of appropriate questions about how she was doing and what we could do to help her. And then at the end, they asked, would we have a way to help them get home? They had no car, and they walked to the hospital from several miles away with their 5-year-old little brother, who was now likely going to be someone they would have to provide some custodial guardianship for. And we see yet again how our community is being really torn apart by these medications. As Greg pointed out, my main sort of driver working with Mike and talking about the message that BeBOLD has is that I have kids. I have a 4-year-old and a 6-year-old, an Avery and an Emerson, and I worry every day that they could end up addicted to drugs. They'll certainly have the opportunity to use them if they want to. I believe that in the course of their life they will be offered these drugs and that they're going to have to be prepared to say no. And so what do we do every day as citizens to try to make this work? I fortunately have the good fortune to be part of another group called Leadership New Hampshire, which sort of travels the state looking at various issues that are happening across the state in all the different regions. And we see opiate addiction everywhere from Coos County all the way down into Manchester and the more populous areas. Certainly it's not sparing any geographic area. It's just the number of people that it affects. And while I was there on our Criminal Justice Day, I met a gentleman named Eddie Edwards, who you may know. He's the former chief of Southampton Police Department. He also was the chief of the Division of Liquor Enforcement. He's a board member of the Partnership for Drug-Free New Hampshire. And we talked about what are the things he thought would be really important in terms of drug abuse and trying to prevent it. And for a police officer who'd been a police officer for many years in many fashions, he said, if you were to give me $1 million today to combat drug addiction, I would use it all on prevention. Because we can make many arrests and put drugs on the table with guns and make it appear that we're taking these drugs from the street, but they're replenished as fast as we can take them away. And our class really started to inquire, what can we do to support legislation to help us get this, these drugs off of our streets? What can we do to make bills that make it harder to get these drugs out there? And I think we really settled on the fact that what we really had to do was just as citizens, we had to start talking to our kids individually. We had to talk to other people who we knew and ask them to talk to their kids and really make sure that we're at our schools and working with the people who lead our schools to know that we don't want any of our kids exposed to drugs and alcohol, and that we have to make sure we're sending that message and really start to explore what does prevention look like? How do we do it? I don't know that we have all those answers at this point, but I know that from a hospitalist perspective, we won't Narcan our way out of this problem. In fact, we may make things only better and try to save some lives, but we also can send the message that, well, we can reverse this now, right? And so there's some safety in that. But I really think it's important that we start to think collectively as communities, how do we do this? And then how do we in our individual sectors in our nonprofit worlds think about coming together to make sure we're sharing all that same information. So you have a great sense of what's out there, and if we have kids and young people who are on drugs now, how do we effectively treat their drug abuse and potentially any other mental health problems that they have that oftentimes associate with drug use. But I think that's really the part that I take home the most, is that none of us individually can do this, but we have to do it collectively. I think that's really all I have for you guys, and I would take questions.
Kevin, I think you got to a point you brought up, and you know more about this than I do, that we were speaking recently about the availability of treatment. And so as a health system, Elliot works really hard to partner both with Catholic Medical Center hospitals in Concord and Nashua, but local resources. You mentioned Farnham Center, Hope for Recovery, Serenity Place, all these other not-for-profit, some faith-based, some secular agencies trying to come up with a plan. And what was stunning to me, as Kevin was telling me, and I'd read this once before, that the best way to get into treatment, as scary as it sounds, is get arrested. If the drug courts are funded and they function, there's actually a structure and a pathway, which stuns me that we can't replicate something that doesn't require you to have handcuffs on to actually get treatment. But I think it was an interesting thing, and I don't know, I'm not suggesting that that is the solution, but I found it interesting that that was actually a structured way the drug courts have with checks and balances to have you in treatment. I didn't know it was that significant. I know that there was issues last year getting funded and stuff. I wish we could replicate a functional way that was coordinated.
Two important points. One is, to answer the question, what does prevention look like? If you took a picture of this room, this is what prevention looks like. Okay? That's how things change. I've been in this business for 38 years, 27 in DEA. There is no DEA agent from Bangkok to the Bahamas to Boston that's not going to tell you that the solution to America's drug problem is prevention and education. We've said that for 30 years. We continue to say it. There is an element that is important so that there's not enough drugs on the street, so if you walk past the park on Elm Street, you're not accosted by 47 dope dealers, right? Or some other place in Boston. So there is an element of supply and demand. But this is what prevention and education looks like. That's really true. And number two, the point that you just made, Doc, is that there are two classes broadly, subsets of people that are addicted. There are some folks that finally reach the white light moment and aha moment by themselves, and they'll walk into a safe station of their own volition and say, this is it, I've reached rock bottom, I'm still alive, but I want to be alive tomorrow. And they'll try to do something about it. They may not successfully complete it, right, as you said, Martina, because we know nationally that most people go through about 7 or 8 cycles of addiction treatment, and either by the end of the 7th or 8th cycle, you're either dead or you've successfully got it under control. But there's another subset of people that don't walk into safe station, and then we come in contact with, right? And at that point, we have a very small window of opportunity where we can make the pitch to them from in our own vernacular, if you will. That differs from everyone else. And sometimes it's successful, sometimes it's not. We've had pretty good success with our program here in Bedford, but it's largely totally based on people that we come in contact with in a criminal justice moment. But let me go back to something else that the doc said here, and that is prescription drug medications, which you said initially, Doc, that we didn't have a healthy enough respect for the addictive nature and qualities of a lot of these drugs back in the early 2000s and late 1900s when these things first got introduced. Now we do. We've made some changes. You've made some changes in the medical industry. But when you look at the teen drug surveys going back just a few years, 34% of the teens will say that it's safer to take a prescription medication without a prescription than it is to get drugs on the street. That's what a lot of teens believe, right? And you're here to say that that's not true.
Oh, we should all answer this. Definitely not safe. So I think, Kevin's heard me say this till I'm blue in the face, I think it was 1983 or 86 is when chronic pain began to be treated with narcotics. Probably, my humble opinion, just one doc saying this, that one of the worst decisions made in healthcare.
7th vital sign, right?
Yeah, well, I think that was good to acknowledge pain, but to structure and make it so commonplace to use these medications, use them in increasing doses. I remember at some point I was just finishing residency, like late 90s, and I saw a patient who was on, I think, 83 times a day of OxyContin. Now, if anyone in this room takes that drug, you will need Narcan. I mean, that's a horrendous dose. I've seen now double and triple that amount on people walking around. And I wonder how they got there. The problem is their whole body has become adapted to this drug, and they need that just to be functional. And that's something, I think, without being overly dramatic, the health system created that situation. We got that person there. I think the other stuff is where, in the last 10 years, we're much better about our prescribing habits. I don't use those medications for a bad toothache. I have to admit, there were times when someone comes in at 4 o'clock in the morning, howling in pain with a big abscessed tooth. I actually take the time now to do a nerve block like a dentist would do. Like take the extra time and get them to a dentist the next day. Because I'm worried about getting them those 6 Percocets by script that's going to start you on a path, because I want to be careful. If I have an alternative, I'm going to find it. I'll use ibuprofen more than I used to. It doesn't mean you can't take those medications. It just means I want to make sure I'm only using them as the place where I can't find something else I can do. Sorry.
Questions? Start here.
So, Greg, you're saying, so those prescriptive medications, right? So we see tons of people, you know, kids, knee surgery, rotator cuff surgery. In your professional opinion, well, if I went in now and rotator cuff surgery, I feel like, do people feel like they should be pain-free after surgery right now, right? Like, because, you know, I joke, every day I'm in pain, and that's how I know I'm alive, right? As you get a little bit older. But how, like, if I came in, I got the rotator, how much medicine are you going to give me? Because just 2 years ago, when Ed had that surgery, he received what we thought was quite a bit of morphine and Percocet. And, you know, after 2 days, like, this is a terrible feeling, and, you know, dropped him off at the police station.
So I think the days of us prescribing 40, 60, 90, because the idea was, let's just be honest, if we give you that amount, you won't be calling me for a refill and it'll make your life easier. I mean, but really, I mean, 60 sounds like a lot, but if you imagine 10 days with 4 to 6 pills a day, that's 60 pills, right? And people take them for big abdominal surgery for, you know, 5, 6, 7, 8 days. But I think your bigger question is, we as physicians have to do better about educating physicians, nurses, the whole team. Here's what you can expect post-operatively. Lots of studies have been done. You can set the patient up for success post-op or for failure. If you make them think this is going to be all a walk in the park and you won't have any pain, that's bad. But if you say, you know, this is what you can expect day 1, day 2, we've probably all been through this in some way, that's a great relationship to have. And then we want to make sure we have the medications available for the right indication for the shortest amount of time. What Steve's getting at is we actually have to now do refills every 5 and 6 days, because if you've broken through, we probably should know that. Like, we should know that at day 6, I thought you'd be off those by now. How come you're not? Maybe I should see you.
Come back in, or if I call you back?
It kind of depends. Both. It can be done a couple different ways. Depends on what class of medications. But a lot of doctors saying, I wonder if maybe I should see you at day 6, because I thought you'd be kind of really at 50 or 60% better by now. Why are you not?
Now, this is a general answer. So do you know, is it like day 5 where you're starting to create this habit? Like, we had a friend that had surgery, and you know, she was on some of the medicine.
I'll touch it. So
I was taking care of her, and you don't want me to take care of you, because I was so obsessed that she'd become addictive that we, you know, let the pain get past her.
yeah.
You know, I didn't know. I was like, we're only doing every 4 to 6 hours, whatever. Another friend goes over, goes, she's in tremendous pain. What'd you do? I'm like, I didn't want to get OD'd, so I just give her like 1 pill, and then like.
I cut it in half, right?
So I think it's interesting, and Dr. Dodd, you may want to comment on this, but I think the, you know, kind of biology of addiction is dependent on the person. So, you know, some people can drink alcohol and some people cannot. But I think when we think about pain treatment, actually you brought up this comment, I tend to think of these medications like chemotherapy. Like, if you have bad cancer, you want chemotherapy. You know it's going to harm you, but you'll take it if you absolutely need to. And I think we should really think about prescribing opiates in the same way. So, you know, if you have surgery and you can get by on ibuprofen, ice, and Tylenol, that's absolutely what you want to do. I also think that the prescription or the prescription drug monitoring program and the laws surrounding that have actually, for me as a physician, been helpful. I tend not to discharge many patients from the hospital. They usually go down to the floors before they leave. But the few that I do, I feel like I now have a leg to stand on. So I can say, the legislators, the state has made a decision that we don't want this many opiates out there on the streets. These will not help you, and we're not going to prescribe them. We don't prescribe them for basically the scenario that you're in. I think that's been helpful, because the patients often recognize that that is the case, where in the past it was very much, you won't give me what I need, you don't know how much pain I'm having. I think the context of this epidemic has allowed people to see that while I may have some pain now, I can clearly see that the alternative of potential drug addiction, if that's even a possibility, is so bad that I probably should try to avoid this. And so that has helped to shape that conversation some. But my sense for you would be, you're exactly right. If someone's giving you or prescribing a lot of opiates, your first question should be, do I really need these? Is this something that I should take? Or what if I don't need them? Can I get by on kind of non-opiate medications? And the PDMP does a great job of telling you, Steve has a checklist here, what are the other things you can give me? And there are many of them that we can try before we have to, really resort to giving opiates, particularly in a patient who wants to avoid them.
I've got two questions. So do you have a sense of how many people become addicted because they were prescribed medication and it got abused in some way, and how many, and where it falls that people are getting on the street, it's a fun party or something like that? Do you have a sense of that?
I mean, I can't answer that question.
You might be able to answer that better than me, or actually the chief maybe.
We'll see if your stats stack up to mine.
I don't think there's any statistics about that, but
There's some.
there is a good news. That for you, for everybody, there is a good news. The good news is that we physicians now think differently, act differently, answer questions differently. If the parents or children come and ask us all these questions, I think the message I like to offer you that any one of you, if all your friends, anytime faced in a situation of taking a pain pill, free to ask the doctors why they are giving it, how much they are giving it, and all of that. See, empowering you to ask the question. If you were here 20 years ago, we doctors might have told you, we are the doctors, we give it, you take it. Times have changed now. You have the power to ask the doctors, doctor, how many days I need the prescription? You know what? Each doctor will tell you that. You know why they tell you that? Because we are aware of it. We are getting a sense of it, how big is the problem is. Believe me or not, I don't prescribe any pain medications anymore. It is very hard for anyone to get pain medications from me. We are being educated more about that. Sadly, we don't have a crystal ball to predict on the first time. I do have a crystal ball to predict, second time, third time. So that's where our brain works a little bit sharper.
To answer your question specifically, at least from the law enforcement side, when I was DA in charge, special agent in charge in Pennsylvania and Delaware, back in 2008, 2009, we monitor CDC numbers for overdose deaths, and we started to see a specific uptick in 2006, 7, 8, 9. And we went back to CDC and we started asking them, why are we seeing a 135% increase in opioid addictions, right? And we went back and dug into the numbers, and the CDC dug into the numbers, and we were looking at 60%, some studies said 64% of the results of prescribed medication overdoses that led to those early overdose deaths back in the early 2000s, mid-2000s. Now, it's flip-flop, right? Because the drug trafficking organizations, particularly the Mexicans, have figured out that they can boost the effect of heroin, which they typically produce in Mexico at a much lower grade quality than Colombian heroin or Southeast Asian heroin, by using a synthetic called fentanyl. And with their help from the Chinese friends, they're able to get fentanyl clandestinely produced. This is the fentanyl that the docs see that are ingested in their patients is not diverted pharmaceutical fentanyl. It is clandestinely manufactured in basements of decrepit places in Mexico, or purchased overseas and sent in large quantities from China. Carfentanil, which is another thing that you've all read about, which is a large animal tranquilizer used by vets. Again, the carfentanil, there's 15 documented cases as of April, according to the Attorney General's office, carfentanil overdoses in New Hampshire alone. This is the stuff, I don't know, have you seen a carfentanil case here yet, any of the docs? No. You can dose them 6, 8, 10, 12 times with Narcan before you get a reaction back.
But
And again,
I just happen to
carfentanil is clandestinely produced and is being sent. You can get analogs of this stuff that'll produce the same effect through the mail, because they can tweak the formulation and the molecular structure enough to escape the law. So that's how difficult it is.
Then back to a follow-up question. I'm trying mind to turn, so you mentioned, I think one of you, that you had worked in Burlington or done training in Burlington. I just wonder, we hear a lot that New Hampshire is the center of this issue. Do you, so when you worked in Burlington, or do you know, is Vermont different or other states different? And if so, if there's any difference in the United States, I mean, what can we take away that says, this kind of thing will make a difference to prevent it? Otherwise, we're left with...
Well,
There is, I'll let the doc talk, but there is a difference.
Sure. I'd say there's regional variation in all of New England states, but all the states have a similar profile of abuse rate of opiates that was not here 15 years ago. And so there's pockets where it's less prevalent or less talked about. I'll let them comment on something else. But then the question you asked was about prescription drug use is at the gateway. So I think it's get a little bit mixed up. There's prescriptions that I prescribe for you, and I'm not a good physician, I've not learned, and I'm still putting you on a regimen of drugs that should be long past you should have needed for your rotator cuff surgery. That's one class. Second class is, you're a crafty patient who's become, interestingly, you like these drugs and you shop all around the area without a PDMP because you're the last damn state in the country to get one.
I'm next to the last.
I'm next to the last?
49. Missouri still doesn't have one.
Missouri doesn't have one? Great. Behind Missouri. We're ahead of Missouri. So we were unarmed, and I would have these uncomfortable conversations with patients, and that's where I used my first chemotherapy line. I said, if you were asking me if chemotherapy needed me, I wouldn't give you that, and this drug is just as dangerous, so I know you're mad at me, and you're screaming at me, but this isn't smart. And then there's another group of people who, when the surveys come out sometimes, Chief, they talk about their first use was a prescription drug, but it wasn't prescribed. It was just purchased. It just happened to be labeled from a manufacturer, which someone brought up earlier, it thought to be safer. It's not safer. It's just cleaner in the moment.
The young man that we had here who became addicted to heroin, who we convinced to go into treatment through our program in Bedford PD, his progression was he started drinking at age 13, 14. He started using marijuana at 14, 15. And then he was going over to his friend's house, whose dad had Crohn's disease, who had Percocets in the medicine cabinet, Doc, what you're talking about, right? Picking out the Percocets out of the medicine cabinet, so we tell you, if you don't use this stuff, take it to the Bedford Police Department, put it in a drop box, get rid of it. That's how it started with him, right out of the medicine cabinet. So that's not unusual. To answer your question about regional differences, New Hampshire last year was third in per capita overdose deaths in the United States, behind New Mexico #1, West Virginia #2, right? What are the similarities and differentiations between us? Well, number one, New Mexico sits right across the border from Mexico, where a lot of these large trafficking organizations exist, and they also had a significant prescription drug problem. Number two, I was reading about prescription drug problems and pain management in West Virginia. Why? Back in 2005, 6, and 7, coal miners. They were lined up at 3 o'clock in the morning in pickup trucks, right? There was a story that the Washington Post did, right? And guess what? That transformed into what they see now, which is clandestinely used heroin and fentanyl. And so we sit 40 miles, 30 miles from an epicenter of drug distribution, which is Lawrence, Lowell, Massachusetts, right? We know that drug trafficking organizations from Mexico and Central and South America ship directly now, bypassing New York City, which used to be the main distribution point in the Northeast, directly to the Lawrence and Lowell area, right? So it's easy to get. People are driving up and down 95, 101, 93, Everett Turnpike, and that's where it's coming from. And you can commit a burglary, steal something out of a house in Bedford, true case, run down, pawn it in Lawrence, pick up 40 or 50 bucks, go directly buy heroin, and come back. And they end up in front of them about 8 hours later.
One of the interesting things, too, around prescription drug use was that I think we all assumed that no one would wake up in the morning and say, I'm going to inject an opiate into my body today. That would be much easier to use a pill form. But I think since the heroin has become very cheap, and oftentimes in a world where there's a PDMP, much easier to get and cheaper now than prescription pills, we've seen many young people whose first experience with an opiate was an injectable, which shocked me, because most people don't even want to get a flu shot, let alone inject heroin at a party. But the availability in the milieu made it such that it's really seemed to be about experimenting with the drug. And so some people do have that one, wow, I took that for the first time, it was really bad, I had this horrible side effect, and that's it, I'm done. And those are the ones that we hope really stay on the path. And then there's others who are much deeper into addiction and really are using heroin as a substitute for pills that they can no longer get because they're essentially just too expensive.
Any other questions?
Just two things. I'm a nurse at Bedford Hill Center. We get a lot of your patients there. And I'm surprised. I consider myself still a new nurse because I've only been a nurse 14 years. But just in these 14 years, I went from my patients being probably 70 to 100. And now they're 24 to 65 is what I get now in a nursing home, which shocks people. It still shocks me today. And they're overdosed on drugs, cellulitis, overweight, addicted. One of our LNA's son thought he was going to have a pill party with his friends and took his grandfather's cardassium. 9 of them died 3 days later. So it's not just opioids or whatever. They're just grabbing anything in any cabinet, anywhere, which is crazy. And the second thing is, these drug addicts are so mentally exhausting. I see many doctors, NPs, just their heads are spinning and they're sick of it, and they just go ahead, give them another dose. So, and I get that because I go home and I'm like, oh, I can't think anymore because they're so good and they're just picking and picking away. I mean, I don't know. We need to be more educated in the nursing system because this is becoming such a new problem and we're not getting it, or we're told to do it on our own. That's why I'm here tonight, because if I didn't come here tonight after work, I wouldn't get anything. I'd have to do it on my own on the website. But you can only read so much. You have to hear it. And I'm lucky that I have 2 kids that I have been telling them all my stories at the dinner table. Those kids don't even want to go near alcohol. They're so scared. They've seen pictures. They've been to work with me.
Keep it up.
So just keep... The news is scary. Just say, look what happened tonight because they did drugs. Look what happened today.
Exactly.
This person just died. I just told my kids about the cardassium patient. But I'm so grateful for you guys coming out tonight because I can go back to my job and say, hey, this is what I heard when I was there, and this is what we got to do. But for you, how do we get through the day with these patients? They are so persistent. They are mentally exhausting for staff and for them. They never sleep. I work all shifts. Doesn't matter. They're up all night pressing that button. It's been 4 hours. It's been 3 hours and 58 minutes. I can have it now. It's a PRN. It's a PRN. I get my scheduled in an hour, and I'm going to ring my bell, and it's just, it's incredible. I just, by the time I go home, my brain is coming out of my ears. Sometimes I tell the doctors, give it to me if you're not going to give it to them, because I'm tired. I don't want to hear it anymore. So how do we deal with that kind of
There's a funky thing you
behaviors?
said there, so I don't know if you caught this. So what she's saying is the drug is scheduled every so many hours and then as needed. Now, you can't predict as needed, right? What she's saying is the patient knows what the lockout limit is, and as soon as needed meant every single second until that time duration expires, and then I can get it. So what are we treating? Like when you've had pain, right? You don't schedule your as needed injection. You schedule your fix, which is, let's not kid ourselves. I saw the hospitals over here nodding, and I'm sure Steve has some comments, because your whole staff deals with this.
So we deal with this on a daily basis. Physician burnout is an unbelievable issue at the organization. Nursing maybe has a better support structure. I'm not sure. I bet they do. But we have to rotate nurses on 8 or 12-hour shifts with certain patients because you cannot take it.
Some of we have to refuse. I'm not dealing with that patient. I will take one of yours.
Right, I'll take 3
for
for that one. But
and we have to agree on it as 2 nurses.
1, 2.
It can't be like something that's just a group thing. We have to work it out ourselves. If not, then they're like, too bad. I have enough problems over here.
2 more questions and then we're out of time.
It's actually not a question, but when you said it's very negative, and I want to turn it into something positive, I think one of the take-home messages is if every one of us goes through our medication cabinets, and it doesn't need to be just opioids. You heard the story about heart medication that harmed somebody. And if every one of us talks to their parents and grandparents, and at least 2 neighbors, friends, spread the word. You can go to police department, there is a box, you can drop it off 24/7. Clean the cabinets, clean the medication cabinets. That's one of the first steps that every one of us can do. Spread the word.
Trying to be negative.
Do it.
No.
To answer your question, though, the I don't know her lady.
Nicole.
Yeah, Nicole.
Oh, I'm sorry.
To answer your question, though, I think there are two reasons why the patient is insisting that they want something. One is personality, that's I can't help you with that. The other thing is, as a medical doctor, I know that the withdrawal symptoms they may go through are horrible.
Oh, I'm sure.
So I think as a physician myself, I used to be very dogmatic about it, very stringent about it, negative perception about it, but we have changed the attitude now. There are some excellent medications like Suboxone, which is a prescribed treatment for withdrawal. The question is, in Elliot, it took almost so many years for us to come to understand that these people really have a problem of withdrawal, so we need to treat them. And I do believe that recently when we started giving Suboxone, patients are feeling better, staff is feeling better, the stress is lesser on the units too. I think this is more or less we educating ourselves, whether it is a withdrawal or it is a personality.
But Ram, I think what you're also saying is that you've got to be clear what you're treating.
Yeah.
So a PRN that's really you getting your dose to stop withdrawal is not the same as a PRN designed for pain control.
Right.
So your medical regimen needs to reflect that. And if you know which one you're treating, there's options, right? You can try to do the right thing. But if you're not clear about that, you kind of mix your message. Your patient's confused, the staff's confused. People start getting really frustrated with each other. So it's a real challenge.
And the tricky part, I think, there too is imagine you have a big cellulitic arm that needs to be filleted open and drained. It's hard to say that didn't hurt. And so you have to treat with oftentimes opiates because their pain the level of opiate tolerance is so high that you need an even higher dose to actually treat that pain effectively, which we really want to do from an empathetic standpoint to treat a patient in pain. On the back end, when that should be 6-7 days out and now things are better and we don't have so much pain, the transitioning point to getting them onto a treatment plan before they end up in the nursing home is something very important because otherwise they sort of end up just sort of one day you have it, the next day you don't. And we know the recipe for that is outpatient heroin, essentially. So, but thinking about how do we even have outpatient providers who can prescribe Suboxone once we transition it from the hospital, because it's very difficult to get a license to prescribe that. You can only prescribe to so many patients, and so if you do prescribe that in your practice, and your whole practice is full of patients who are withdrawing from opiates, it's often it's a difficult waiting room, and so you may lose some of your other patients, and so there's a lot of stigma that still goes along with this that I think we're learning together, and as we do that, and we sort of evolve our thinking, I think we'll be much better armed to sort of continue to fight the epidemic.
Dr. Baxter, Dr. Desrosiers, Dr. Loosigian, thank you so much
Thank
for
you,
joining
Chief.
us
Thank
here
you, Chief.
tonight
Thank
for
you.
BeBOLD speaker series. Informative, impactful, powerful, must know, must have information for the community. This is what prevention looks like. Thanks, Doc. Thanks for
Thank you.
joining us.